wabarakatuh. Good morning, ladies and gentlemen, and welcome to the Adjunct Professor Lecture of Pediatric Dentistry Department of Universitas Erlangga. And I'm Afifah. I will be your host for today's event. First of all, I would like to greet our esteemed speaker, Dr. Amol Patil, PDS FDS, the Associate Professor at M.A. Rangunwala Dental College and Hospital. Good morning, Doctor.
Good morning.
The Honorable Professor Dr. Cindy Cornelia Nelwan, Dr. Gigi, Specialist AGA Consultant, Head of Pediatric Dentistry Department of Universitas Erlangga. Good morning, Professor Cindy.
Yeah, good morning. Thank you all.
Yes, the Honorable Professor Tania Saskianti, Dr. Gigi, PhD, Specialist AGA Consultant, Head of Pediatric Dentistry Study Program, Universitas Erlangga. Good morning, Prof. Tania.
Good morning, everyone. Dr. Patil.
Morning, Ma.
Yes, the respected lecturers and staff of Pediatric Dentistry Department of Universitas Erlangga, and all participants joining us today. It is a great privilege for us to learn together in this session with Dr. Amol Patil, who will deliver a lecture entitled Optimizing Clinical Outcomes in Regenerative Endodontics for Immature Teeth. Allow me to briefly explain today's agenda. The first agenda is opening session. The second agenda is lecture session. The third agenda is question and answer question. And the last agenda is closing session. Now, for the opening remarks, I would like to respectfully invite Professor Tania Saskianti, Dr. Gigi PhD Specialist KGA Consultant, to deliver the welcome speech. To Prof. Tania, the time is yours.
Okay, thank you, Dr. Afifa. Hi, everyone. Hi, Dr. Amol Patil.
Hello,
Good
ma'am.
morning.
Good morning.
Thank you so much. Yeah, it is so easy to reach you. For the first time, we meet in person directly in
Yeah,
Bupati. And then we still keep in touch by
yes.
the direct message Instagram, and then we can meet each other again and again later in another lecture through the Zoom online session. We are very thankful to have you amidst
I'm
your
grateful actually.
yeah, very busy and your valuable time. You still want to deliver your lecture to us. We believe that your lecture will be very insightful for us, will open more wider to our knowledge, up to the what is it, the this lecture, yeah. And we hope that we can have another session for the endodontic lecture or any kind of lecture from you, Dr. Amol Patil. And once again, we want to say thank you, and we hope we can have more lecture, and good luck for the presentation today. Thank you so much, Dr.
Thank you so much, Prof. Tanya. Actually, it's a privilege for me to be attached with such a prestigious, the oldest institution or university in Indonesia, and to
Thank
deliver a
you.
lecture as an adjunct professor in your university. The overall people, what I found when I visited Indonesia is all are very kind and warm-hearted. So that's what I really liked about the people in Indonesia, and I'm really thankful to have been delivering this lecture in front of you all. So, should we proceed with the presentation? Should I share my screen? Or should we
Ah,
wait for
we,
Professor
yeah,
Udi?
Dr. Afifa will continue. Send my best regard to your wife, Dr. Amol.
Thank you. Thank you so much. I'll do that.
Yeah,
Definitely.
Dr. Afifa, thank you, please.
Yes, thank you, Prof. Tania, for the welcome speech. First of all, Doctor, before we go to the main session, which is your lecture, please let us to introduce you as our distinguished speaker for today's session. So, Dr. Amol Patil, PDS, MDS, is an associate professor at A. Rangunwala Dental College and Hospital, Pune, India. He completed his bachelor in dental surgery from STCH, Pune, MUHS, and completed his master in dental surgery in periodontics and preventive dentistry from PDT, Sangli, also from MUHS, both with first class distinction. And he has a strong academic interest in pediatric endodontics and has contributed to scientific publications, including a textbook chapter on aesthetic crowns in pediatric dentistry edited by Dr. Nikhil Marwah, as well as lectures and hands-on workshops at both national and international levels. So without further ado, please welcome our speaker, Dr. Amol Patil, PDS MCS. Dr. Patil, you have about 45 minutes for your presentation. The time is yours.
Thank you so much. So, without further ado, I'll start with my presentation. So, first of all, I would just like to ask you all, am I audible? Am I clear? Is there any difficulty in the voice?
Clear,
It's
sir.
clear, Doctor.
Thank you. So, greetings of the day, everyone. Selamat pagi, as you say in Indonesia. Uh, as I mentioned earlier as well, I'm very much delighted to share the insights and the knowledge which I have gained over a few years while practicing pediatric endodontics. So I'm going to share that with you all. Thank you for the invitation as an adjunct professor at the University of Erlanga. So before we proceed, I would just like to ask you all about one case. Like, for example, if a patient, 9-year-old male patient, visits to your OPD or outpatient department, complaining of trauma to the upper right front tooth, like tooth number 21, and he has a non-vital tooth, uh, open apex, wide open apex. So, what will be your treatment plan in that case? Are you going to create a barrier or apexification or revascularization? And how you're going to decide about it? If anyone can answer, or else you can do one more thing. I'll open the chat so you can just answer uh, all of you can answer it in the chat box. Meanwhile, I'll just continue with my presentation without due because we only have 45 minutes to finish this off. So all of you can just answer this question: which treatment strategy you're going to opt for and why? So at the end, we can discuss this case once again. 9-year-old patient, immature roots, so had a history of trauma to the tooth number 21 with open apex, non-vital tooth. Treatment plan of your choice. So going ahead, in such cases, there are two treatment approaches, usually either apexification or revascularization, as this is a non-vital tooth. Okay, we're going to discuss it in the further slides. So, just a minute. Yeah, okay. So in this table, it's very clear if at all a patient comes with a immature tooth, then we need to first divide it into the vital bulk therapy treatment and non-vital bulk therapy treatment. In case of vital bulk therapy treatment, we have apexogenesis, whereas in the case of non-vital bulk therapy treatment, we have just a minute. I'll just use the spotlight. So in this case, you can see. So either we have apexogenesis, which is a vital pulp therapy treatment, which can be either pulp capping or partial pulpectomy. I'm going to show you some of the cases regarding this. Secondly, if the tooth is non-vital, then in that case, we have four approaches like revascularization, apexification, bioceramics, or a surgery. So, sorry for that problem. Okay. So what is apexogenesis? By definition, it's actually a procedure that deprives the coronal injured pulp from the root canal of an immature permanent tooth with a vital pulp. The goal over here is still vital and able to mineralize the root dentine, allowing the continued maturation and physiological development of the roots. The success rate is around 82 to 96% in cases of apexogenesis. Whereas in case of apexification, we create a barrier at the root apices because the case over here is a non-vital tooth where we remove the necrotic pulp, disinfect and induce the calcific barrier. Success rate varies from around 80% to 90%. There are certain limitations. It does not promote root maturation. It cannot thicken the dentinal walls, which are weak in case of immature tooths. Therefore, it does not improve the fracture resistance as well. So I'm going to give you all some of the references for your exam purpose, because you might need to write down your essay questions and there might be a question on young permanent tooth or treatment strategies. That's the reason I have added some of the references. You can take the pictures and you can use these references during your uh, theory exams. So, what is regenerative endodontics? Is a biologically based procedure for immature teeth with necrotic pulp or irreversible pulpitis. In such cases, we induce the bleeding, so-called as stem cells of apical papilla. With the help of the scaffold, we promote regeneration or continued root development in such cases. There are certain studies which says that the success rate ranges from 50% to 90%. Although the success rate in case of regenerative endodontics is minimum as compared to apexification or MTA barrier, but still the advantage over here is root dentin thickness can be enlarged and tooth can regain its vitality. That's why it's called as revitalization technique. Just to differentiate between apexification and apexogenesis, apexification is most commonly carried out in non-vital tooth, where there is an open apex, where we create a barrier so that the root formation can continue. Uh, and in the cases of an apexogenesis, it's carried out in the vital pulp. It's a vital pulp procedure where we carry out in the vital tooth, where we used the vitality of the tooth to induce the root formation naturally. So this is a natural root formation procedure. There are other terminologies like conventional root canal therapy. Always carried out in cases of non-vital or irreversible pulpitis cases where the root is mature. Whereas apexification, apexogenesis, and revascularization is mostly carried out in the cases where the root is immature. Another terminology is partial pulpotomy. It's carried out in the cases of apexogenesis, where we remove around 2 to 3 of coronal pulp tissue and we place a biomimetic material that is most commonly empty or bioidentity so as to form the root. Whereas revascularization, which is nowadays called as revitalization, it's a procedure carried out in non-vital tooth or teeth with irreversible pulpitis, which disinfects the root canal with antibiotics, and we induce the bleeding, thereby promoting the tissue healing, which can cause mineralization and strengthening of the dentin, and it can help in maturation of the roots. In 2001, Iwaya et al. Was the first person who carried out revascularization in the patient, although it was first introduced by Nygaard Osby in 1968. But later on, in around 2001, she tried it in the patient, and post that, she introduced the term of revascularization. Nowadays, it is called as revitalization because revascularization is just the formation of vascularity, whereas revitalization is maintaining the vitality of the tooth, which was proposed in 2008 by Huang and Lin. So, coming to the regenerative endodontics history, in 1961, Nygaard Osprey introduced it, whereas in 2001, Iwaya et al. Was the first person to carry out treatment in the patient. In 2004, Bax and Trope, they proposed revascularization using triple antibiotic paste. That is a disinfection of the root canals with the help of the triple antibiotic paste so as to promote healing, so as to induce the vitality of the tooth structure. Coming to the chart again, so over here we're going to divide the two patient. Whenever a patient comes with an immature apex, we need to first divide it in either the vital tooth structure or is it a non-vital tooth. If it's a vital tooth, we can carry out apexogenesis with the help of the pulp capping or partial pulpectomy. Whereas if the tooth is immature and non-vital, either because of the trauma or because of the caries or because of the hypermineralization, then in that case we have certain options. The traditional options were apexification and biospheric barrier. Recently, we can carry out revascularization or a surgery as well. I'm going to discuss each one one by one with the cases. So in this case, you can see where tooth apices are open. The tooth is non-vital, so working length was determined. Post that, calcium hydroxide was placed inside the canal and it was remained in the canal for almost a 4 weeks time. So the procedure of apexification is long period. It takes long treatment time period. It has a predictable outcome. The success rate is around 90%. It is comparatively inexpensive because calcium hydroxide is not that expensive, and it is less technique sensitive because anyone and everyone can uh, place a triple antibiotic paste intracanal very easily. It's not difficult to place. The only problem in cases of apexification is root dentin thickness cannot be enlarged. We are not going to revitalize the tooth, so vitality will not be maintained. There will be a barrier creation. So we need to re-enter in such teeth after 4 weeks time period. That's why it's long treatment time period procedure. Moving ahead, next part was bioceramic barrier. So recently, instead of going ahead with the traditional technique of apexification with calcium hydroxide, everyone is moving ahead with the bioceramic materials. Bioceramic materials are further divided into aluminate and tricalcium silicate based materials. Most commonly used bioceramic materials are tricalcium silicate based materials because they are more potent to induce the stem cells. They are more potent to induce dentin like tissue or cementum like tissue. They are again divided into mineral trioxide aggregate, biodentin, or bioceramic putties, which are most commonly used for such procedures. So, coming to this case, again a patient around 11-year-old, she visited with the chief complaint of pain with this tooth. Although the tooth was non-vital, because of the food impaction and other problems, she had a pain associated with this premolar. So, post working line determination and irrigation and disinfection, a empty apical plug was placed. The apical plug of around 5 to 6 was placed in this root. The reason being, usually there are ramifications present in the apical region. So to seal off all the ramifications, around 5 to 6 of MTA plug was placed. Over to it, obturation was carried out with MTA obtura. It's a thermoplasticized gutta percha. So in this case, what we did, we have created a barrier with the help of the MTA. So this is MTA plug technique, where we create a barrier at the apical end and we obturate the coronal third of the root. So this is again a part of non-vital plug therapy. Moving ahead with one more case. Again, this patient visited with history of trauma. Ellis class 4 type of trauma happened with 1-1 and 2-1. So patient had a periapical lesion as well. So initially, after taking a working length, intracanal medicaments were placed. Post that, MTA apical barriers were placed in the canal, and over to it, obturations were carried out. So this both of these cases were of MTA apical plug or bioceramic plug. As I discussed earlier as well, bioceramics are divided into bioinert, bioactive, and biodegradable materials. Most commonly used are calcium silicate based because they have a potency to induce the stem cells. They have a potency to create a barrier faster as compared to other bioceramic materials. Nowadays, everyone shifts to MTA putty based materials, which are easy to place inside the root canal or root apices. Just to show you all how to place the MTA apical barrier. This is a video which demonstrates the placement of the apical barrier with the MTA putty. So this is bioceramic putty. So this is the MTA plugger. With either we can use MTA plugger to push it down, or we can use a micro brush. In certain cases, these are hand pluggers which we can use in the cases of narrow canals. In this video, I've tried to show all the different techniques how to push the MTA plug in the apical region. You can also use gutta points. In this case, first we need to determine the working length, then cut the apical end of the gutta and push it further so as to push that MTA plug in the apical region. So this is how you can obturate the canals completely with the MTA plug. Or in certain cases, if you need to just put the apical plug, we can remove the coronal part of the MTA with the help of the H files. So moving ahead, the benefits of bioceramic barrier are it is quick because we can in a single visit we can place the MTA apical plug. The outcome is predictable again. In this case, the success rate ranges from around 80% to 90%, and it is comparatively expensive. Expensive in terms in certain cases or in certain countries, the dentists don't charge much for the endodontic treatments as it's a need-based treatment objective. So in that case, if you're going to carry out uh, a bioceramic barrier, then MTA becomes costly, so the treatment expenses increase. That's why it is comparatively expensive when you compare the price of calcium hydroxide with MTA or a bioceramic-based material. Again, it is technique sensitive because any novice or any new dentist will be unable to place a proper thick 4-5 mm apical plug in the open apices cases. There is a chance of slippage of MTA from the apices and beyond, and it can cause a foreign body reaction. So it's a technique sensitive procedure. So these are the benefits and limitations of bioceramic barrier and apexification. Going ahead, in this chart, we have covered till now apexification and bioceramic barrier. We'll first finish off with the vital treatment strategy, that is apexogenesis. For this, either direct pulp capping or partial pulpectomy can be carried out, such as in this case, if there are deep caries and the tooth is asymptomatic, patient complains of pain which disappears when stimulus is removed, which suggests that this case is a reversible pulpitis. Then in that case, pulpal exposure during caries is materials. Like in this picture, you can see there is a pinpoint exposure while caries excavation. So in such patients, we need to first disinfect the cavity post caries exposure with hypochlorite. Post that, we can place a bioceramic putty like MTA putty on the exposed part. So this is the complete case where you can see the pictures of the occlusion, the upper arch and the lower arch, where the patient complained of pain with both the lower first molars. And these are the pre-operative pictures of the tooth number 36 and 46. Post-caries excavation, there was a pinpoint exposure which was sealed off with MTA putty. Followed by it, full coverage restoration was carried out. So this was about apexogenesis. The tooth was vital. The symptoms are of reversible pulpitis. So in this case, just the empty apical. Is there any question? Should I continue?
You can continue, doctor.
Okay. Am I going too fast? If that's the case, just let me know. I can slow down. Is it okay? Should I continue?
It's okay. It's very clear.
Okay. Okay. Thank you. So in this case, you can see a radiographic picture where you can see the MTA was placed on the exposed pulp tissue. Over it, a restoration was carried out with RMGIC, followed by a stainless steel crown, a full coverage restoration on the tooth number 36 and the 46. These were the post-operative pictures for the follow-up. And in such cases of apexogenesis, where the root apices are open or immature apices, just with the placement of MTA on the exposed pulp, we can carry out a maturation or we can induce the natural root formation in such cases. So this is a part of apexogenesis which was carried out. There is no need to intervene again. This was the post-operative occlusion of that patient. The next technique in apexogenesis is pulpotomy. In the cases where caries exposure is not limited to the pinpoint or zero point 0.1 mm, it is going beyond that, then in that case, patient might complain of deep caries. The tooth will be symptomatic in this case, and pain which will linger when stimulus is removed, which is suggestive of irreversible pulpitis. But the tooth is vital, it's not non-vital. and the apices are immature. So in such cases, post-carrier excavation will understand that there is a uh, sufficient amount of pulp tissue which is vital. So remove the inflamed coronal pulp. Post that, we can place the MTA in the pulp chamber, followed by RMGIC, and then the full coverage restoration. So in all the procedures, either it is a vital tooth or a non-vital tooth, in all the cases, we need to use a full coverage restoration. A coronal seal is a must because there is a chance, there is a probability that if the coronal seal is broken, then there is a chance of secondary leakage, which might lead to the failure of the procedure. So this is the full case where you can see a preoperative picture where there is a carious lesion on post that, the caries were excavated under isolation. After caries excavation, the bleeding was arrested with the help of the hypochlorite. Followed by that, MTA was placed on the pulp chamber. This is like a normal pulpotomy which we carry out in the primary tooth. Just in this case, we can either carry out a partial pulpotomy or a complete pulpotomy. In case of Sweck's partial pulpotomy, we need to remove 2 to 3 mm of the coronal pulp tissue with the help of the spoon excavator. And in the case of complete pulpotomy, we can remove complete coronal pulp tissue followed by a bioceramic material. This is one more case where you can see radiographically the caries were involving the pulp and the apices were open. So the pulp chamber was opened up, all the caries were removed. After that, all the inflamed coronal pulp was removed. It was disinfected. Post that, MTA barrier was placed, followed by a full coverage restoration. So till now, we have talked about non-vital traditional treatment techniques like apexification and bioceramic barrier. And in case of vital teeth, apexogenesis, how do we do it in cases of pinpoint exposure and the carious exposure? So with the help of the pulp capping and partial pulpectomy. Going ahead, the main topic of interest of today is revascularization. So I'm going to focus on it. Plus, I'm going to talk a little bit of theory part so that you can understand it better. And by the end of this session, you will be able to identify and differentiate the cases, or you will be able to select the cases for revascularization, how to select the cases, and how to gain a success in that. So, first of all, I'll just show you one of the case. 9-year-old girl, she visited with the chief complaint of pain with the lower left six, that is 3/6. So, post that, working length was determined. Instrumentation was not carried out as instrumentation is not recommended in cases of revascularization. Post that, for the disinfection, triple antibiotic was placed for 21 days. One more dressing was given, that was calcium hydroxide. I'm going to discuss this part, why these dressings were given and for why that much time in further slides. After that, the bleeding was induced and MTA was placed in the pulp chamber on the blood clot. This is the follow-up picture, immediate post-op picture, where we can see the full coverage restoration. So clinically, this is the picture where you can see the canals were clean. Second picture, you can see the bleeding was induced. On that bleeding, MTA was placed. So radiographically, you can see over here the apices will start to close up. So this is the follow-up where you can see 1 year follow-up where root were maturing. The second picture, radiographic picture showing 2-year follow-up and 3-year follow-up. So in between this part, from 2 year to 3 year, we had one issue. The patient reported with broken cap with this tooth that was full coverage restoration was broken. So we replaced that Bioflex crown with the stainless steel crown in this case, and you can see with the 3-year follow-up, the root is completely matured. Although there is one problem, there is a obliteration of the root canal, but this is not a limitation or this is not a failure. This is considered as a part and parcel of revascularization, where you can see closure of the root apices or a barrier formation. Another case, in this case, Patient reported with a complaint of pain and open apices, immature apices. The tooth was non-vital. So again, the working length was determined. Canals were irrigated. Post that, actually, patient didn't turn up for almost 6 months. So when he turned up, the thing was his mesial canals were completely closed. So instead of inducing the bleeding in that case, we obturated those two canals with the Gataparka points, and the distal canal was also closing. So instead of going ahead with revascularization, we did empty obturation within that canal because the resorption has already started. So this was a treatment strategy which was changed later on because patient couldn't come up for the follow-up. So this can happen with you as well. So that's why there is one more indication for revascularization. The patient should visit for the certain period of time for the follow-up. Otherwise, the treatment strategy cannot work or revascularization will not happen. For that reason only, in this case, instead of doing revascularization, obturation was carried out in the mesial canals with the Gataparka points, and in distal canal, the obturation was carried out with the MTA. So this is the follow-up where resorption has halted in the 3 month and the 6 month follow-up. You can see that the roots were completely closed, so revascularization was impossible in this case. So this is the complete case where preoperative picture, post-op, follow-up pictures were seen, and full coverage restoration, Bioflex crown was given in this case. This is the occlusion of that patient. Moving ahead, revascularization is not full and final treatment objective because the success rate is pretty low in case of revascularization. It accounts to around 60% only. Reason being, there are multiple indications or multiple limitations to this treatment strategy. Like in this case, the patient reported with a complaint of pain and the non-vital tooth, immature root apices. So initially, intracanal medicament was placed in both the canals. Later on, there was a root closure which was identified on the mesial root. So again, in this case, on the mesial root, we started with the obturation with Gadapaka points. Whereas in the case of distal canal, where the root apices were open, intracanal calcium hydroxide dressing was given, and post that, the bleeding was induced. But the problem in this case, which happened, is patient came up with the swelling again. So distal canal was again negotiated and obturated with Gataparka points followed by the crown. So it's not full and final. That's what why I'm trying to say over here, and that's the reason I showed you both the cases where in one first case patient couldn't come up for the follow-up, and because of which the treatment plan was changed, and in the second case patient reported with the infection with that tooth where revascularization was carried out, and for that reason the treatment plan was again changed and root canal was carried out. So, just to give you a glimpse of all these procedures, revascularization is time consuming because we need to keep the patient on follow up. In this case, the patient should at least visit us for 6 months of time period because initially we're going to keep intracanal medicament for 21 days. Post that, 1 week of calcium hydroxide, and then we can induce the bleeding and place the biosonic material. But the patient should visit us again for follow-up so as to confirm the root formation is going on or not. And that's the reason it is time consuming. There is a huge variability in outcome because if the patient couldn't come up for the follow-up or patient has any medical conditions, then in that case, outcome can vary. Revascularization also improves apical closure and cervical thickening. That's the benefit. We get dentinal thickness and there is a possibility of revitalization. Whereas in the case of bioceramic barriers, it's a quick treatment strategy because in a single visit, we can create an apical barrier, obturate, and we are done. It has a predictable outcome. The success rate is around 80 to 90%. Barrier is only apical and there is no cervical thickening. That's a limitation because dentin thickness cannot be increased. Lastly, in case of apexification, it is again time consuming. Reason being, we need to keep calcium hydroxide intracanal for 4 weeks. Post that, we need to again recall the patient, check if the apical barrier is forming or not, and then we can again If needed, one more dressing, or we can finalize with the obturation. But the predict outcome is predictable. Again, the success rate is from 80% to 90%. It is less technique sensitive as compared to the revascularization and bioceramic barrier. And barrier is only apical. Again, in this case, there is no cervical thickening. So this is about revas, bioceramic barrier, and apexification. Is there any question till now? Should I move ahead? Because I'm going to talk more about revascularization henceforth. I'm not going to talk about bioceramic barrier and apexification. Should I go ahead?
Yes, please, doctor.
Okay. So there is this recent research which was from 2025, which states that the stem cells exhibit essential MSC characteristics. So including specific marker expressions, self-renewal, proliferation, migration. So this is about stem cells of apical papilla. So these cells have the specific characteristic of showing a proliferation or migration. So because of which there is a possibility of formation of root dentin thickness, there is a formation of cementum-like dentin-like tissue at the apical end and create a revitalization of the tooth. So this is the picture from that same article. In this study, what they have shown is these are the stem cells of apical papilla, and those apical papilla stem cells, they have shown the CD4 characteristics, CD73, CD90 characteristics. So these characteristics states that these cells have these cells have the potential to induce the vitality in the tooth structure, and because of which everyone nowadays is talking about revascularization or regenerative endodontics or revitalization techniques, and that's what we are going to say in the further slides. So, how to select the case for revascularization? The patient's age should be 6 to 17 years. Why 6? Because in certain cases, certain patients have early eruption of the first permanent molar and immature root apices. Most commonly in the cases of molar incisor hypomineralization, these patients have early involvement of the pulp and it early becomes necrotic. So in such cases, we might need to go ahead and use a revascularization procedure. And for that reason, from 6 years to 17 years. Why 17 years? Because most commonly in the cases of adults, like most 18 years and older are considered to be as adults. And in that case, root opening will be minimal. It's more less than 0.3 mm. And wherever the root apical opening is less than 0.3, it is very difficult to induce the bleeding and to carry out a revascularization procedure. For that reason, the age criteria is from 6 to 17, where the possibility of regenerative outcome is better and the success rate is better. Second step is obtain a medical clearance for the patients with compromised healing. The reason being, some certain patients might have healing problems with the patients of diabetes patients, or certain patients who have hemophilia or hemorrhagic disorders. In that case, is bleeding. If the bleeding is induced and it doesn't stop, then that can be a problem for that patient. For that reason, medical clearance is a must. Patient should be compliant. As I showed you earlier as well, one of the patient did not report to me again for 6 months of time period. Until that time, intracanal medicament was there inside, and because of which there was a closure of the root apices, and so we couldn't continue with the revascularization. So patient should be compliant. Patient should come for the follow-up. Then only we can carry out this procedure. Next, the swelling or any visible lesion or the defect or the sinus tract should be treated. This means that intracanal infection should be cleared out before you induce the bleeding and carry out a revascularization. For that reason, we need to keep triple antibiotic paste inside the such non-vital teeth for at least 21 days so that all the ramifications, all the accessory canals, wherever there are anaerobic infections, which will be completely eliminated and the success will be better. Next part is immature permanent tooth with thin dentinal walls. Uh, it means that the apical opening should be at least 1.1 mm so that the stem cells will be effectively encroached inside the in the root canal, and there will be formation of the root dentin thickness. Then the dental pulp should be necrotic or has irreversible pulpitis. As this is a non-vital treatment strategy, the tooth should be non-vital. In case of vital tooth, we either carry out apexogenesis with the help of direct pulp capping or pulpotomy. The normal tooth mobility and is restorable. The tooth should have a normal mobility, not more than grade 1 or grade 2 or grade 2. The tooth should not be avulsed and replanted within 15 minutes. If there is a case where patient report to you with a Ellis class 5, that is, the tooth is avulsed and it was replanted within 15 minutes, then we need to go ahead with apexification procedure, because again in this case already there is a trauma. The tooth is completely out of the socket, and because of which there is a possibility of injury to the stem cells of apical papilla, and which might not induce the regeneration. If there is no crown root structure, then again we need to stop that procedure. We can't go ahead with the revascularization because we need a hermetic seal coronally as well. So the crown should be restorable. Root canal can be adequately disinfected, that with the help of the calcium hydroxide and triple antibiotic paste. Root apex is open wider than 1.1 mm and bleeding fills the root canal. So this is a must. If the bleeding is not induced or if the bleeding is not completely filled up in the canal, then the success rate will again decrease. Regenerative endodontics may be attempted in such cases where the scenario is feasible. Now, why patient age 6 to 17 that we discussed? Why not less than 6 or why not in deciduous teeth? Because deciduous teeth are already meant for exfoliation, so they should not be tried in primary tooth. Then it should be tried only in the young permanent tooth. Again, in the cases of patients who have age more than 17, mature benefit because the dentinal thickness is already there. The main benefit of revascularization is formation of dentin-like tissue in the apical ends. Mature adult with the permanent tooth, conventional root canal therapy is more preferable as compared to revascularization because success rate is more in cases of closed root apices with the root canal therapy. We also need to obtain a medical clearance for the patients who are on blood thinners or who have uncontrolled diabetes or uncontrolled bleedings. In such cases, it can impair the healing and it can lead to treatment failure as well. So, medical clearance is a must. If revascularization endodontic therapy is not suitable, apexification is a better alternative to manage necrotic immature permanent tooth, as the success rate is also better, 80% to 90%. Again, we need a compliant patient. As per the statistics, it states that only 39.5% of the pediatric patients comply with the follow-up dental visits. Most of the patients stop attending once the pain is gone, and they don't understand the importance of visiting again because the root maturation is incomplete. And if at all the treatment is incomplete, it may leave antibiotic paste inside the canals. There might not be any obturation, no final restoration. So again, the prognosis is poor in such patients. In cases of patient with the swelling or sinus tract, if the infection is not completely removed, like swelling is not completely halted, sinus tract is still there, and the hermetic seal is not present, then because of the micro leakage, because of that, there is a chance of compromised healing, and because of which the treatment outcome can vary. And this is the main reason because of which the the treatment outcome in case of regenerative endodontics is 60 to 80%, not more than that. It is most commonly done in the patients with thin dentinal walls, like in the young permanent teeth or patients who are less than 17-year-olds, because in that case, we need those dentinal walls to get thickened up. We need that dentinal thickness so that root will not fracture later on. If in such cases we go ahead with apexification or empty apical barrier, then in such cases there is a possibility of root fracture because of the thin dentinal walls. But if the patient is compliant, if all the criteria are met, and we are going to carry out a revascularization in such cases, then the root dentin thickness will increase and the possibility of root fracture will decrease. Again, it is carried out in the patients with necrotic or reversible pulpitis. This we have seen already. Uh, the regenerative endodontic therapy is not needed for immature permanent teeth with vital pulp or reversal properties. In that cases, apexogenesis is a better option. In such cases, we need to remove the necrotic pulp, disinfect the canals, induce the bleeding. We can either use a scaffold of PRP or PRF, which has multiple growth factors, which can induce the tooth-like tissue form inside the tooth, and it can revitalize the tooth again. Ideally, the root apical opening should be 1.1 mm. It should be wider more than 1.1 mm. If it is less than 1.1 mm, then in that cases it is better to go ahead with apexification or empty apical plug, because we need to induce the bleeding, and the bleeding and stem cells should come till the CEJ, that is cement to enamel junction. If it can't come to that level, then it is very difficult uh, to carry out a revascularization. And for that reason, the criteria is apical opening of the root, immature root, should be greater than 1.1 mm. So this is one of the criteria for revascularization, because it is critical for adequate blood inflow. And the wider the apical opening, the better the chances for revascularization. So in the cases where patient comes to you with a non-vital tooth, immature roots, then you also need to check it radiographically, the apical opening of the root. If the apical opening of the root is less, then go ahead with apexification or MTA plug. If it is more than 1.1 mm, we can go ahead and try revascularization, as it can help in formation of root, increasing the root dendritic thickness and revascularization of the tooth as well. Now, moving ahead with the disinfection, most commonly used disinfection is triple antibiotic paste and calcium hydroxide. Why? I'm going to discuss it in the further slides. Triple antibiotic paste is nothing but ciprofloxacin, metronidazole, and minocycline, just to cover up the discoloration. Instead of minocycline, we can use clindamycin or cefaclor. It should be used in zero point 0.1 milligram per ml concentration for 1 to 4 weeks. The reason I'm going to again discuss in the further slides. Why 4 weeks? The irrigation protocol is 20 ml of 1.25% sodium hypochlorite. Why? Because when we open the necrotic tooth with immature open apices whose apical opening is more than 1.1 mm, then in that case we need to be cautious, use side vented needles or endovac so that the irrigant should not flow beyond the apices, but it should be kept, irrigation should be done 1 mm lesser than the apical opening. We need to disinfect all the intercanal part with hypochlorite so that all the internal shavings or infected part of the root should be disinfected. Post that, we need to use EDTA. Why EDTA? Because EDTA will induce the growth factors like TGF, that is tumor growth factor, and all the other growth factors which can provide us a sterile environment for the uh, stem cells of the apical papilla. It will provide the growth factors and which can induce the revitalization in the tooth. And the final rinse in the canal should be carried out with the saline. The complete procedure we're going to see in the subsequent slides. Differential diagnosis to select the treatment for immature teeth. The choice of endodontic treatment in immature teeth depends on the pulp status. Is it a vital tooth, non-vital, or it's just a pulpitis case? Based on that, we can decide either to go ahead with apexification, apexogenesis, conventional root canal therapy, or revascularization. So this is a pictorial presentation which was given in Endodontic Journal by Murray in 2023, which states that if that root canal cannot be adequately disinfected or bleeding cannot be controlled, or if the patient cannot come for the follow-up, then in that case, it is better to go ahead with the endodontic retreatment, that is conventional root canal therapy, instead of going ahead with the regenerative endodontic therapies. If the tooth is traumatized or diseased and with the open apex, then in that case, if the tooth is vital, go ahead, and in that case we can do a partial pulpotomy, that is apexogenesis. If the tooth is non-vital, then in that case we need to check the root canal wall thickness plus the opening. If the thickness is if the thickness is not there, sorry, the apical opening is not there, then in that case apexification. If the apical opening is more than 1.1 mm, then revascularization can be tried. So this is a roadmap how you can decide in which case we can go ahead with root canal therapy in which case apexification or apical barrier, in which case we can carry out a revascularization. This is a Swick's classification or stages of root development. It states that uh, in the first stage, as you see, the apical opening is more than 1.1 mm. The root the maturation of the root is almost half. In the second stage, it is more than half, and the third stage is two-third. Fourth stage, it is almost complete, and the fifth stage is complete. So, in the cases where the apical opening is less than zero point 0.3 mm, that is stage four. So, up to stage three, that is A, B, and C, we can carry out revascularization. In case D, it is best likely that we need to go ahead with apexification or apical barrier, and in the case E, root canal therapy is a better option. So what is the mechanism? There are multiple theories which are advised. Like first theory is periodontal cell theory. It states that there are multipotent periodontal cells which are present just below the root apices, immature root apices, which can differentiate into cementoblasts and fibroblasts. Out of that, cementoblasts will help in root maturation or completion, whereas fibroblast will help in formation of pulp-like tissue and increasing the thickness of the dentine. The second theory states that residual pulp cell theory, it states that there are residual multipotent stem cells which can again adhere to the dentinal walls. They can induce the odontoblasts-like tissue formation, and because of which there will be a root closure. The most accepted theory is stem cells of apical papilla theory, which states that in at the apices, there are stem cells of apical papilla which can migrate into the root canal when we induce them, that is, induction of the bleeding. And these cells have high proliferative potential. They can multiply rapidly, and because of which they can create tooth-like tissue inside that root. Because that blood clot which was induced, it has a scaffold of growth factors and stem cells. When they come in contact with the MTA or any bioceramic material, there will be a tissue regeneration or continued root development which can happen. So this is the most accepted theory which we usually follow, that is stem cells of apical papilla. There are some other theories like growth factor mediated regeneration. This is because when we use a natural scaffold like patient's autologous blood with the help of the PRP or PRF, it has multiple growth factors, and in such cases, the success rate is more. That's the reason there are different theories which are suggested, like growth factor mediated regeneration or bone marrow stem cell theory. In all of this, what they try to say is whenever there is a stem cell inside the root, with the growth factors, the success rate is more. The root maturation is faster, plus it is better. Now, what are the advantages of revascularization? Root lengthening and strengthening will happen because the thickness will increase. Restoration of the neurovascular system, because in such cases, they have tried to check the vitality of the tooth with the help of the cold test, that is ice test, post the complete root maturation, and the vitality, the patient has given the signs and symptoms of vitality, and because of which it is stated that when we do revascularization procedure with the help of the with the help of the stem cells of apical papilla, then in that case restoration of the neurovascular system can also happen. There is a reduced risk of root fracture and return of tooth vitality. What are the limitations? Patient compliance is a must. There is a possibility of tooth discoloration in this case because we are going to keep a bioceramic material in the cervical part of the tooth, which can cause a discoloration. So crowning is required, that is full coverage restoration is required post revascularization. Then there is a possibility of unpredictable cell content of a blood clot, which can create tooth-like tissue. It's not always like cementum is formed, odontoblast-like tissue is formed, or a pulp is formed. It's cementum-like, pulp-like tissue which is formed. This is because of the blood clot which is present. Then there is a possibility of intracanal calcification or obliteration, which I have shown in one of the cases where there was obliteration of the root canal at the third year follow-up in that 3-6, tooth number 3-6. Now, coming to the procedure, what is the procedure? First, we can give the anesthesia, local anesthesia with the vasoconstrictor at this stage. Access opening will be carried out post removal of all the carious part. Working length needs to be determined. Now there is there are two different school of thoughts over here. Recently, the authors are stating that we need to do a minimal canal instrumentation so as to remove all the infected dentine from the intercanal part, and that minimal instrumentation will be done with the K file only, not with the H file, not with the rotary file. But this minimal instrumentation is necessary as per some authors or some school of thoughts. And some say that there is no need for instrumentation. Just remove the in necrotic pulp, irrigate with the hypochlorite, EDTA, like place the intercanal medicament and induce the bleeding. Whereas some school of thought say that take the exosoplin, remove the pulp, do a minimal instrumentation to remove all the necrotic dentinal shavings, post that, disinfect with the triple antibiotic paste, calcium hydroxide, and then you can induce the bleeding. Now, intercanal medicaments are of two different types. We're gonna come to that. Then dry the canals, follow the irrigation protocol, and post that you can induce the bleeding. Now, in this case, you can see patient had a deep carious lesion associated with lower right mandibular first molar. So, preoperative radiograph shows incomplete root formation and increased periodontal ligament space with the mandibular right first molar. So exocytoning was carried out. Post that, working length determination was carried out. In this case, only pulp extravasation was done. Instrumentation was not carried out. So when we irrigate, we need to either use endovac, it's irrigation delivery system with a side-vented needle, or closed-end needles, because we need to irrigate these canals with a 20 ml of hypochlorite. Why 20 ml? Because there are multiple ramifications, accessory canals in the teeth, and that irrigant should reach to all the ramifications, all the accessory canals. And again, there is one author, Dr. Anil Kishan, which states that irrigant should remain in the canal for at least 3 to 5 minutes, and for that reason 20 ml of sodium hypochlorite should be used for the irrigation, because that 5 minute will reduce the log of bacteria from 10 to the power uh, 10 to the 10 to the power 6, not completely eliminating all the bacteria, but the log will reduce at much higher level when we keep the sodium hypochlorite in the canal for 5 minutes or more. That's why 20 ml of hypochlorite is recommended. Why 17% EDTA? Because it induces the growth factors, because of which EDTA is also recommended. Post the irrigation with the hypochlorite, we need to irrigate the canals with 20 ml of 17% EDTA with side vented needle again for 5 minutes. This is the first visit when we do that. In the next part, we going to dry the canals, place the intercanal medicament. So intercanal medicament can be calcium hydroxide or triple antibiotic paste. Now, why calcium hydroxide? Because calcium hydroxide will increase the pH in that region. So there are two different things which we're going to do. First, we're going to place calcium hydroxide for a week, because calcium hydroxide uh, it comes in form of calcium hydroxide mixed with the water or with the saline, which can stay in the canal for a week's time. Post that, it can dissolute and the efficacy will decrease. So it needs to be placed in the canal for a week's time. It will increase the pH in the apical region, which is conducive for the stem cells. Secondly, post that, we're going to keep triple antibiotic paste for 3 to 4 weeks. This will reduce the microbial load in the apical region. So this is to reduce the microbial load, because there is a possibility of presence of anaerobic infection in the apical region. In the concentration of 1:1:1 ratio, with 200 milligram of ciprofloxacin, 500 mg metronidazole, and 100 mg minocycline, we can replace the minocycline with say clindamycin or cefaclor. So the target over here, metronidazole will have an effect on anaerobic conditions. Ciprofloxacin will have an effect on gram-negative facultative anaerobes. Minocycline, again, either clindamycin or cefaclor, it has effect on gram-positive and some gram-negative microorganisms. So because of which we need to keep it in the canal for 2 to 3 weeks, because it is going to disinfect all the dental tubules, accessory canals, and apical ramifications. And triple antibiotic paste is usually mixed with the glycerine. So it can stay in the canal for 3 weeks. It has an efficacy to disinfect the canal for 3 weeks, 2 to 3 weeks, and because of which we're going to keep it for 21 days, which will eliminate all the bacteria, reduce the inflammation, and initiate the tissue healing. And post that, we can induce the bleeding. So, defining clinical and radiographic success in such case, clinically, patient should have absence of pain, no swelling. Radiographical success, if there is complete absence of reduction or stasis of radiolucency, this is actually not seen immediately. This will take time. Radiographically, we can see the success after 3 to 6 months. Patient comfort, post-operative pain should be measured on the VAS scale. Post 24 hours, patient should not feel any kind of pain in such scenarios. So,
Excuse me.
yes, yes, ma'am.
Excuse me, doctor. Kindly a gentle reminder that you have about 3 minutes remaining for your presentation.
Okay, okay, thank you. So, I'll just try to cover it off fast. So triple antibiotic paste should be used in zero point 0.1 to 1 mg, not more than that concentration. If the concentration of triple antibiotic paste increases more than that, then it can injure the stem cells of apical papilla. For that reason, 1 is to 1 is to 1 in a concentration of zero point 0.1 mg. We can measure the paste on the weighing scale of, and it should be zero point 0.1 of each part so as to reduce the toxicity. Why calcium hydroxide, as I discussed earlier, it has a high pH, which can encourage hard tissue formation. It has again antimicrobial effects. It can increase the pH, which will create a conducive environment for the stem cells. The second appointment for revascularization, in this case, we're going to give the anesthesia because we need to isolate the tooth. But in that case, in second visit, we're going to give anesthesia with mepivacaine, not with the adrenaline, because we don't want vasoconstricted over here, as we are going to induce the bleeding in the canal. So irrigation again with hypochlorite and EDTA, then dry the canals. We need to induce the bleeding. In the first appointment, we have taken a working length. With the working length is around 12 mm. Then recurve the file and push that file beyond the apex. That is, it should be pushed beyond 12 mm. It will induce the stem cells of vagal papilla. Then we need to control the bleeding with the help of the with the help of the PRP or PRF. Put the MTO over it, and then the final restoration for the coronal seal. Blood clots, there are different benefits of the blood clots. It has different fibrin matrix, which can have the growth factors, which will induce the root formation and the pulp-like tissue formation. PRP and PRF, these are the scaffolds which can take from the patient's own blood. This will help in faster healing, faster stem cell recruitment, and tissue regeneration, and the success rate is more. So this is the procedure where you can see the acellular PRF and fibrin clot, that is PRP and PRF. So we can remove that part, keep it in the canal on the bleeding, and over it we can place the MTA. So coronal sealing is again an important aspect. So we can seal that part of MTA with the cola coat. It can act as a barrier, and over it we can restore with the composite or with the full coverage restoration. Outcome, it is variable. Patient should not have no pain, no swelling, no sinus tract. Secondary goal is continued root development, and tertiary goal is return of neurogenesis or vitality as per the AA recommendations. And again, there is a radiographic classification which states that the success can be of 5 different types. Type 1 states apical aperture closing and the root length and thickness is also increasing. Type 2, there is no increase in the thickness and the length of the root, but the apical opening is closed. Type 3 states that roots are growing thicker and longer with an open apical aperture and there is an obliteration at the end. Type 4 is calcification or obliteration of the root canal lumen. And type 5 is the hard tissue layer that sits between the clot, sealing substance, and the root apices of the teeth. So we want a success, class 1, type 1 or type 2 type of success over here, not the other three. So this is what was about revascularization. Going to the last part, this is the surgical part which was there. So in cases where patient has non-vital tooth, we have seen apexification, bioceramic barrier, revascularization. One more option is surgery. So in which cases we can do that? Like in this case, the patient reported with a non-vital tooth. On 3D radiograph, we understood the patient has external resorption which was happening, which you can see in this 3D CBCT. So a stent was designed for this patient just to seal off this external resorption with the help of the bioceramic sealer. Surgically, the site was opened up. Post that, MTA was placed. During the placement of the MTA, the Gataparka point was placed inside the canal so that MTA should not go inside the canal and block the canal. So this is the radiographic pictures. First picture states that there is presence of external resorption. Working length was determined. Then tooth preparation was done. Master cone was selected. Post that, surgically the site was opened up, MTA was placed, and then the obturation was carried out. So this was the stent over here. With the help of the stent, uh, at the specific site, the surgical site was opened up, and after cleaning of the surgical site, MTA was placed. This is post-operative picture after suturing and the healing of the patient. So to conclude, there are multiple treatment strategies which are available for the young permanent tooth. Either it may be vital or non-vital. First, we need to decide treatment strategy based on the indications and contraindications of each technique. There are benefits with each treatment strategy. The success rate also varies. So we need to decide and differentiate between different treatment objectives. And based on the needs of the patient, or the specific requirement, we can choose a specific treatment strategy for that patient. I hope I have covered everything and it was understandable to you all. Because of the limited time period, I have to rush through, I have to talk fast. So if at all there was any difficulty, you can ask me right now. I can again go through the slides or share the cases with you all if you want. Uh, so that's what about revascularization or the regenerative treatment strategy for young permanent tooth. Thank you so much.
Okay, thank you so much, Dr. Amol Patil, for the very insightful and excellent presentation. Now we will proceed to the Q&A session. For the participants, if you have any questions, please write them in the chat box, or you may use the raise hand feature if you would like to ask directly.
You can
Please go
ask
ahead.
directly. Yeah.
Hi, doctor.
Hello, sir. How are
How
you,
are
sir?
you?
I'm
Thank you.
fine. I'm fine.
Sorry, I cannot join the earlier because I have a problem with my laptop. Anyway,
Okay, no issues.
can I ask you some easy question, I think?
Yes, yes,
But
sir.
I just want to
Sure.
ask you about could you give us a kind of tips or tricks giving anesthesia for the pulpectomy treatment? I mean, we know that this is very challenging for giving the anesthetic for the children, right? So
Yeah,
could you give us some tips
yeah,
or
for
tricks
sure.
for
So,
giving anesthetic?
uh,
Thank you.
yeah. So in cases, what I prefer or what I follow, uh, I usually use a cartridge, and before using a cartridge, I use distraction techniques. Like I must have told you initially as well. I have a sedation unit in my operatory. So in certain cases where the patient is completely uncooperative or Frankel's behavior negative or definitely negative, in that cases I use sedation. In the patients who are Frankel type 1, where they are slightly negative or just positive, in that cases I usually try to distract the patient by either playing a television on just above the chair, also have a word with the patient, make a rapport with the patient, then just by distracting, I give the anesthesia. In certain cases, I use a sedation technique like nitrous oxide oxygen inhalation sedation, which because of which the anxiety will be completely reduced and patient will not feel the pain, which they feel usually with the prick of the pain. One more thing is while giving anesthesia, I make sure that I deposit zero point 0.5 ml of anesthesia initially, then wait, let that settle in so that the mucosa is anesthetized, and then I give the complete anesthesia. So I give it in parts. Uh, Plus 30 gauge needle, I most uh, commonly prefer to give the anesthesia as it is thin. The penetration is not felt. Prior to that, again, I make sure to dry the mucosa, place a topical for at least 2 minutes, and then prick it. Pressure also plays an important role. So while giving the anesthesia, I make sure to deposit it at 1 ml per minute. So because of which patient will not feel pain. Also, in addition to that, in cases where the patient has a swelling or a patient has a hot tooth, then in that cases, I usually give periosteal injections as well, or intraligamentary injections, which helps because in most of the cases, pediatric patients, if their age is 4 years, 5 years, then complete neurogenesis is not formed. The ramifications are still developing, because of which, even though we have given inferior areolar nerve block, patient might feel pain. So in that cases, I usually prefer to give buccal, and in addition to that, intraligamentary, so that patient should not be in a pain. There are two most important aspects of patient management, as I think, is one, to manage the behavior, and second, to give the proper good anesthesia. Post that, any treatment strategy is very easy because patient is cooperative, and mostly children are more cooperative as compared to the adults. So this is my treatment strategy which I follow. Uh, what I am learning right now is intraosseous anesthesia. It's a good technique. Instead of giving a block, if you're going to work only on specific tooth, then intraosseous anesthesia works wonders, because we don't have to give multiple injections. Like if you're giving inferior nerve block, we need to first give uh, the inferior nerve block, then buccal, then infiltration. Instead of that, we can just give intraosseous anesthesia. There are multiple devices which are available in the market. So that's a better option. I don't have that, I don't use it, but I have seen it and I'm planning to buy it. Hope that answers your question. Hello.
Apologize, Prof. Ude. I think your microphone is still muted.
Uh,
Sorry. Okay, thank you.
Thank you. Thank you. I can see some questions which are asked in the text box, chat box. Can I read those questions and answer it?
Yes, of course.
Yeah, there was one question by Dr. Kinton. In immature permanent teeth with necrotic pulps, how do you decide between single visit MT apexification and regenerative endodontic procedure, especially in cases with wide apical diameter but thin dentinal walls? So, as I shown you the chart over there, there was one chart which was displayed by AE, American Association of Endodontics. It states that if there is an immature permanent tooth with necrotic pulp, that is non-vital tooth. So as the tooth is non-vital, the treatment objectives over here are either apexification, empty apical plug barrier, or revascularization. So if you're going to go ahead with the revascularization, the dentinal thickness, as mentioned over here, the dentinal thickness is wide apical barrier with thin dentinal walls. So if the apical diameter is more than 1.1 mm with thin dentinal walls, then in that case, it is better to try revascularization first, because even if it fails, we have a chance to create the apical barrier later on with the MTA. So there are three treatment objectives. One is apexification, MTA barrier, and revascularization. Out of that, revascularization is better because it is going to create a tooth-like structure. It is going to increase the dentinal thickness. And as mentioned in this question, apical diameter is more, but the dentinal walls are thin. So in this case, revascularization is a better treatment objective. If at all patient couldn't come for the follow-up, if the patient's follow-up is not maintained and later on if the patient comes with a problem, we can anyhow go ahead and carry out empty apical barrier in a single visit and obturate it. So in such cases, what was the question? Based on this question, in such case, revascularization is a better option. Even if it fails, we have options like creating an empty apical barrier, or what I did in one of the cases was root canal therapy, where revascularization failed, we can go ahead and do root canal therapy. So that's what is a better option in such case. Hope that answers the question. The one more question was regarding, do you consider stem cells of apical papilla recruitment through induced bleeding sufficient to achieve meaningful dentinal wall thickening in immature teeth? It's an excellent question because, as I mentioned, there are multiple theories which states that either stem cells of apical papilla uh, are going to get induced and they're going to create a barrier. In addition to that, the success rate also depends on growth factors. It also depends on disinfection of the canals. It also depends on the use of different intercanal medicaments. Uh, if the canals are not completely disinfected, if their canals are not completely irrigated nicely with ADTA and hypochlorite, which will create a conducive environment for the stem cells, and also if the growth factors are not there, then depending or relying only on stem cell of apical papilla will not help. It will fail. So that's why there are certain criteria which should be made. First of all, the tooth should be non-vital. It should have immature apex with thin dentinal walls. Apical opening should be more than 1.1 mm, which can help us to induce the bleeding. Secondly, uh, we need to disinfect the canals nicely with a triple antibiotic paste, irrigate with a 20 ml of hypochlorite, 20 ml of EDTA, then calcium hydroxide dressing to increase the pH. Post that, when we induce and when the bleeding is coming till CAJ, it is getting sealed up nicely with the help of the PRP, PRF, which can promote the healing by providing growth factors. Then and then only the success will be better. So it's not only the stem cells of apical papilla. That's one of the theories. It also depends on the complete treatment part. Like we need to select the case first properly, disinfect it nicely, and after that use of PRF and PRP as a scaffold. This will increase the uh, thickness of the root apices. I hope that answers this question. Is there any other question?
Okay, is there any question from the participants? Okay, perhaps that's all, Doctor. That concludes all the questions from today's session. Uh, Unfortunately, we have now reached the end of our session, so I will just close the session. Thank you, Dr. Amol Patil, and all of the
Thank you so
participants for
much.
the engaging discussion. On behalf of Pediatric Dentistry Department, Universitas Airlangga, we would like to express our deepest gratitude to Dr. Amol Patil for sharing your valuable knowledge with us today. And we sincerely apologize for any imperfections, and we hope this session has brought new insight and benefit to all of us. Before we close, we would like to invite Dr. Amol Patil and all of the participants to take a group screenshot for documentation purpose. Can you please first stop the share screen so we can have the screenshot? Okay, let's take a group screenshot for documentation purpose. Start with the first page in 3, 2, 1. For the next page, 3, 2, 1. Okay, that's all. Once again, thank you for your attention and participation. With this, I formally close this session. Have a great day. Wassalamualaikum warahmatullahi
Thank you
wabarakatuh.
so much.
Waalaikumsalam
Thank you,
warahmatullahi. Thank
Matashi.
you,
Thank you.
Dr.
Thank you.
Amal Patil.
Thank you
Thank
so much.
you,
Thank
See
you.
you
Doctor.
Bye-bye.
again at the next lectures.
Thank you. Thank you. And if at all there are any further questions, you can ask me on the WhatsApp. I guess Dr. Yukibed is in contact with me. She has
Okay.
arranged this meeting. So she or anybody else also can share the questions. I am